my name is Bobby Spurlock. I'm a licensed clinical social worker, and I am certified in perinatal mental health. This is my colleague, Sarah Landis. She is a doctor of physical therapy, and she specializes in the pelvic floor. And we will be presenting to you tonight on the impact of pelvic floor dysfunction on perinatal mental health, with special focus on marginalized and rural communities.
So today we are going to be talking about pelvic floor dysfunction and all of its various forms and how it affects people in all different phases of life. However, the postpartum population is more prone to physical dysfunction. Physical dysfunction can lead to increased rates of depression and anxiety during that postpartum phase. We're also going to be highlighting marginalized postpartum rural communities and just how susceptible they are to pelvic floor dysfunction, mental health concerns, because of so many different things that we're going to talk about. So, a few definitions to get us started. Rural communities are defined as urban areas that are less than 50,000 people. This is just what the research states. We just want to make sure that we're honing in on who these people are.
Marginalized communities, for the purpose of our presentation today, are people or populations and groups and communities that experience discrimination and exclusion, social, political, and economic, because of unequal power relationships across economic, political, social, and cultural dimensions.
Pelvic floor dysfunction. Huh? That's what we're talking about. This refers to a broad constellation of symptoms and anatomic changes related to abnormal function of the pelvic floor musculature. The disordered function corresponds to either increased activity, so that hypertonicity, or diminished activity, so hypotonicity, or inappropriate coordination of the muscles of the pelvic floor.
And the perinatal period is defined as any time from the moment of conception through the first year of your child's life.
And here we go, diving right in. So today, the most common pelvic floor dysfunctions seen in this perinatal period are prolapse, incontinence, and dyspareunia. So we're just going to not waste any time and just dive right into what prolapse is. There are many different types. One is the cystocele, which is where your bladder is coming through, and we don't like to say falling into the vaginal canal, but moving in that direction. And these are different pictures of all of these. Enterocele, which is that small intestine, can actually come through. Rectocele is your rectum. Uterine coming all the way down and into the vaginal canal. And then the actual vaginal vault can also prolapse. Again, this is most commonly seen in this perinatal period, but is also common throughout life. And you don't have to have a baby to have prolapse. So something important to remember. For the purposes of this, we're not going to go super deep into how we grade them, but there are different grades of prolapse. So all things to pay attention to, because the most common symptom that we see, and we'll go over symptoms, but especially coming to a pelvic floor PT, is I have something hanging between my legs. I have this heaviness feeling at night or in the morning, and they just can't necessarily quite figure out exactly what this is. Of people with prolapse in this perinatal period, 50% of women will have some degree of prolapse in the perinatal period. I'll let that resonate for a moment. That's half of the population that we're dealing with that are having babies are going to have some degree of prolapse. Of those, 10 to 20% actually experience symptoms. The prevalence of prolapse is higher, of course, after a vaginal delivery than a cesarean section. However, one study found that women who had operative vaginal deliveries were almost twice as likely to experience pelvic organ prolapse, right? So we can talk more about the operative deliveries, but it just means that there had to be surgical intervention to the vagina specifically. Other risk factors for pelvic organ prolapse include infant birth weight, current BMI of the delivering mother, genetics, aging, chronic straining with constipation, and then pelvic organ prolapse may, of course, negatively affect sexuality, body image, and of course, quality of life. Definitely important things to pay attention to. There was a study done in 2021 that looked at prevalence of prolapse by race. And what they found was white women were the most likely to have pelvic organ prolapse in this postnatal perinatal period. It went down then from to Hispanic and Black women, Asian Americans. And the truth is, American Indians and Pacific Islanders were absent from this current prolapse study. Just let that sit for a second. Why do we think that they were absent from this study? Are they not having these symptoms? Are they not experiencing prolapse? Or is research just not paying attention? It's highlighting that fact that we can do better from a research perspective and hopefully within our communities to highlight these different things. What are the symptoms that people might experience with prolapse? Like I said, that fullness, that heaviness feeling in our pelvic floor, lower back pain. I can't tell you how many patients come in and are just like, oh, I don't have any pelvic symptoms, but I'm here, but my back just really hurts. I'm like, okay, all right, let's address that. But let's also address all of the other things that are also associated with it, right? So that bulging feeling in your vagina, feeling like something is slipping out or falling out, leaking urine can often be a cause, right? So that incontinence, and we're going to dive more into that, but it can be a symptom of prolapse. Repeat bladder infection. Again, that has to do with the positioning of the bladder neck and where it's at and how it is affected. Difficulty pooping, especially with that rectum, if it is falling through, a lot of people actually have to splint. So what that means is either putting their finger into their vaginal canal and pushing the poop back and out through their rectum. Some people can even just put their finger on their perineum. This is so common that they make a device that you can buy on Amazon, right? It's a plastic little scoop, and you just so that you don't get your hands dirty while you're pooping, and you just place it on your perineum to help give a little bit of posterior pressure, right? This is how common it is. And of course, problems with sexual intercourse. If you, one, the psychological component, and we'll dive more into that, but if you're feeling like something's falling out, you might not want something else in there, right? It's just a thought. And then, of course, problems inserting tampon. So some people, depending on what it is, cannot hold a tampon in or will actually have pain or difficulty inserting with prolapse. So the prevalence of prolapse, the reason I included this study was because it was done in a rural community. Again, it's harder to find research done on rural populations. This rural population was actually in Pakistan, and they found that 10.3% of women had clinically confirmed prolapse. That means that a diagnostician actually stuck their finger in the vaginal canal to be able to determine if they had a prolapse. Women with 3 or more children had the highest proportion of prolapse. But 60.8% of those women reported great to moderate effects of their quality of life, right? That's why we're here talking about this, because it affects their quality of life. 44.3% had symptoms for more than 5 years. That's very significant. And 78.7 never even consulted a doctor about it. So that's what we're seeing a lot, especially, and we'll dive more into that in these rural communities, is you're going to the doctor for something that is catastrophic because you have to get in and you're talking to them about life emergent situation. The fact that something might be falling out at that time, that might not be highest priority, especially in rural healthcare. This is seen so commonly. So looking more at those rural communities, the odds of actually having pelvic organ prolapse were 2 times more prevalent among women in rural communities than those in their urban counterparts. 2 times. So what's going on, right? Why is it that much more common in rural communities? Well, here's one thing, and I think so many of us in this room can relate to it. Women had a history of carrying wood. How many of you out there have carried wood? We're about 105.8 times more likely to develop pelvic organ prolapse than those who were not. I won't be carrying wood anymore. But the truth is, that's just one activity that they measured. What are all of the other activities that women living in rural communities are having to do on a daily basis that could be affecting their prolapse slash pelvic floor slash quality of life. So different things to pay attention to. All right. You ready? We got through prolapse. Everyone's feeling good, feeling like their parts are inside. Hopefully, especially sitting down, we're giving a little help in that little fecal. We'll talk about that maybe. So incontinence, right? So this is where you are actually leaking urine or feces. You're leaking something out of a nether region orifice. So there's a bunch of different kinds of incontinence. Stress incontinence, right? Those are those people that come in who are lapping, sneezing, coughing. Oh, it's not a big deal. I just can't jump on the trampoline with my kid because I'm leaking urine every time that I do that. That's stress incontinence, right? Purge incontinence, key in the door incontinence. You're going somewhere and, oh gosh, I just can't get to the bathroom in time. Help me. That's that urge. You can't make it to the bathroom. Overflow incontinence. This occurs when the bladder does not completely empty itself, causing frequent or constant dribbling. So you go to the bathroom, then you stand up and you dribble, right? We see these things in our clinics on a daily basis. Functional incontinence, a physical or mental impairment that prevents someone from reaching the toilet in time. I just got to work with patients in a skilled nursing rehab kind of facility. If you're with a walker and you just got your leg amputated and you're trying to learn how to walk and get to the bathroom in time, you might have some incontinence, right? So different things put in place to help these things. And then mixed incontinence, that's that good old combination. We can't wait. We have all of it. We just want all of it to be under one title. And then there's nocturnal uresis, and that's that chronic bedwetting. I always bring this one in also just because it really does affect people, not just in the perinatal period, but something to look at in our youth populations too. They have pelvic floors, just like everyone in this room has a pelvic floor and can have issues with it as well. So loss of urine at night can happen in all different ages and phases of life. So physical symptoms with incontinence, obvious, right? Leaking urine. That's kind of part of the definition. However, this can be attributed to skin problems. If you're constantly wet down there, you can get skin problems. You can get rashes. You can get infections and sores. And a very common thing is also urinary tract infections. Because all of that is just sitting there, bacteria forms and gets into all of those other fun places that we don't want it to be in. So how prevalent is incontinence? A 2021 study found that 1 year postpartum, 55% of women experienced incontinence. Again, this isn't specific to any kind of incontinence, but we can extrapolate, right? Any kind of incontinence still should not be happening, especially at 1 year postpartum. I don't care how many people or providers or anyone tell you, oh, no worries. You're still postpartum. You're still healing. You should not be leaking, right? And there's so many different things that we can do about that. Is it more common, especially right after having a baby? Yeah, of course. And should there be things that we're doing? Yeah, of course. At any time, at any phase of life, there's things that we can do. A 2023 study found that by the 2-year postpartum mark, 43.5% of women were still experiencing urinary incontinence. So this isn't something that's going away, right? This is happening still, even further out in that postpartum journey. An older study looked at and found that 33.1% of white women, 14.6% of Black women experience urinary incontinence in the postpartum period. I think the reason that I put this in here and the whole point is we're studying only two groups of people. And I get that in research, sometimes you can only study 2 groups of people. But the truth is that we are a multicultural world and we need to be doing better with our research so that we can be doing better to help all of these patients experiencing these symptoms. So incontinence in rural and marginalized communities. A study done in 2020 looked at incontinence during pregnancy and compared Hispanic versus non-Hispanic white women. It was determined that Hispanic women reported 7.5 points greater incontinence symptoms than their non-Hispanic white counterparts. So where is this study coming from? Are we just comparing those two different groups of people? The truth is we're all having incontinence. And yes, some groups are having it more than others, but why? And what are we actually doing about it? I think is the important part. An older study done in 2006 looked at the percentage of incontinence, and it was found that 36% of Hispanic women, followed by 30% in white women, 25% in Black, 19% in Asian American postpartum women, were all experiencing incontinence. So, is there a reason that certain groups of people are experiencing more incontinence? Again, more research needs to be done. But, right, we've now talked about prolapse. We've now talked about incontinence. We are now talking about what was called and still is a lot in the literature, dyspareunia, which is better, the new fancy term is genitopelvic pain. Genitopelvic pain, it's the diagnosis of vaginismus and dyspareunia, and they collapsed it into this single entity called genitopelvic pain / penetrative disorders. So what we're looking at, and it's defined by 5 different dimensions, asking patients and discussing these different things. The percentage of success with vaginal penetration, pain with vaginal penetration, fear of vaginal penetration, or genital pelvic pain during vaginal penetration. I never thought I'd say penetration so many times in one slide. I'm going one more time. I'm getting it. I'm going to. Pelvic floor muscle dysfunction and different medical comorbidities, often referred to as dyspareunia. So you will see in the next couple slides, some of the research actually calls it dyspareunia. I want you to know that we're talking about the same thing in this case. Basically, what it is painful sex. Okay. So any kind of painful sex. So what are the symptoms? Painful sex, right? But it's broader than that. And that's what we're talking about. So pain during penetration, but just at the entry. Sometimes, especially in our postpartum moms who have had any tearing, they might have pain just at what we call the introitus or the opening of the vaginal canal, depending on where they tore, right? They can tear all the way to the clitoris. Like that's still considered pelvic pain. That's still considered dyspareunia. Deep pain with thrusting activities, burning, aching, or throbbing pain that lasts for hours after sex. Some people are completely fine having sex. And then hours after, oh my gosh, it feels like a knife is stabbing me. This again is in this diagnosis. Pelvic cramping, muscle tightness or spasms, feeling like something is being bumped inside of you might be a prolapse, but it can cause pain. And that's why we're talking about it. And then, of course, pain that feels like menstrual cramps. So how common is this? What is the prevalence? A study done in 2022 by Rosalind et al. Determined that 31.4% of women had dyspareunia 3 months postpartum with no significant difference in the delivery method. That's something that should hopefully resonate. It doesn't matter if you had a cesarean or a vaginal delivery, or necessarily if you tore. All of these populations can still have pelvic pain with sex. And that's not fun. There's nothing fun about it. And there's so much that we can do. So 11.9% of women continue to have dyspareunia 2 years postpartum. Again, are they talking about it? And what are their providers helping them with? What is happening in their communities and in their home and in their relationships that is going on while they're still having this pelvic pain? And what can we do as providers to help with it? And pain, catastrophizing, greater fatigue, and depressive symptoms were indicators of the severity of the dyspareunia. So just something to note there. Getting back into this rural and marginalized communities, little or no research has been done. Why are we only focusing on urban white women? Let's focus on all different populations in all different communities, in all different stages of mental and physical health. And little or no research is done in the marginalized communities. So the take home with pelvic floor is there's still a lot to learn, right? We can still do so much. There is no sufficient explanation for the radical disparities observed in your pelvic floor dysfunction treatment outcomes across the United States. One possible explanation for this is that women of color and immigrant populations are largely absent from randomized controlled trials. How do we get them in? Because they're living in these rural communities and they're a little bit harder to track down. And with that,
All right.
Bobby, take it away.
Take it away. So we are going to begin to switch our focus a little bit, keeping in mind everything that Sarah has just shared with us about symptoms and prevalence. We're talking about 50% of perinatal women. This is a huge number of people. And so we're going to start looking at what are the mental health effects for these women and what does this look like for their families. And so I want to start with talking about the fact that, like perinatal mood and anxiety disorders, pelvic floor dysfunction is a risk for all pregnant and birthing persons. It doesn't discriminate. It's a risk. It doesn't matter if you've had a vaginal birth, a cesarean birth. If you've been pregnant, you have an increased risk. And what we know about perinatal mental health is that a major risk factor for developing a PMAD is an unexpected or an adverse birth outcome. And a pelvic floor dysfunction is a common adverse birth outcome, which is what we'll see a big leading factor in the development of perinatal mood and anxiety disorders. And pregnancy and childbearing are the leading risk factors for developing a pelvic floor dysfunction and the primary cause of pelvic floor trauma. Talking about the research when it comes to pelvic floor dysfunction and perinatal mental health. And Sarah alluded to this already, but the fact of the matter is there's a decent amount of research about women in general and their mental health related to pelvic floor dysfunction. There's not a ton of research that looks specifically at women in the perinatal period. What we know about women in general and pelvic floor dysfunction is that these women who have moderate to severe pelvic floor dysfunction are reporting lower perceived quality of life and suffering higher rates of anxiety and depression. And Sarah pointed out before that we really have very little information about minority and marginalized communities in the research. I was able to find some, but a lot of the research that we are presenting today primarily is looking at white cisgendered females. And so keeping that in mind as we move forward. So Sarah talked a lot about quality of life. And when we talk about mental health, I think that's a really great place to start, right? And so this study that I'm going to talk about right now was done on women in general. It was not a perinatal specific study. This was a study done between 2021 and 2022 in Spain. And this study really showed that women with pelvic floor dysfunction reported lower perceived quality of life in all dimensions of the quality of life that were measured. So these women were suffering consequences on a physical level, on a psychological level, a sexual level, and consequences to their social health. These women reported social isolation. They reported effect to their performance of daily tasks. They reported loss or effect to their personal and intimate relationships. And they reported reduced participation in leisure activities. And another really important thing that this study showed us is that even though all of those components of quality of life were impacted, the emotional component was the most impacted in these women. So if we take a moment to look a little bit deeper into quality of life and pelvic floor dysfunction in the perinatal period, we really want to think about what this means for these women or these birthing people. And it's important to remember that birthing people are navigating all of these quality of life challenges during what is considered to be a critical window for their mental health and for infant mental health at the same time. So when we're talking about physical quality of life in the perinatal period and what this can mean or what kind of impact this has on birthing persons and families, what we're really looking at is women who are potentially impacted in ways that maybe they can't pick up their baby. Maybe I've always imagined I'm going to be able to carry my baby and I can't. Maybe I can't get on the floor with my baby. Maybe I can't even sit comfortably to breast or chest feed my baby. So everything that I imagined about how I would physically care for my infant may be impacted now by physical symptoms related to my pelvic floor and or a pelvic floor trauma with my birth. Typically not expecting this. Psychologically, This is a period when we already know all women are at higher risk of developing mood and anxiety disorders. And then we add an unexpected birth outcome of a pelvic floor dysfunction. We call it unexpected because we're not talking about it, right? Women should be expecting that this is the likely chance because 50% of us are dealing with it, but it's unexpected because we're not talking about it. And so we're increasing this risk even further. What does it mean to have a further sexual impact during a perinatal period? It means that at a time when an intimate relationship is already impacted by normal, if we can call it that, healing, we may have long-term impacts on a relationship. I may have never went into a relationship thinking, I'm going to have a baby, and I might not be able to have sex and enjoy it again after that. Women don't know that's a possibility. Their partners don't know that's a possibility. But this is something that women are dealing with on top of everything else in their perinatal period. And then when we're looking at their social health or their social interaction, we're talking about decreased quality of life between relationships with the partners, with their children, maybe their new infants, and their friends or their support people, right? These people that we know are critical during this time in their life. We're talking about women who might have reduced access to support related to social isolation, which peer support groups, right? We know peer support is critical in this time. We have women who, due to shame, due to incontinence, who might not be able to get out of their house. They might not be connecting, right? So this can be a huge impact in creating further mental health issues. And then reduced access to physical coping skills. We know there's a lot of research that tells us that physical activity helps reduce postpartum depression. These are women who, related to their pelvic floor dysfunction, may not have access to something that could be very critical in this postpartum time. One of the biggest things we're facing, in my opinion, is that while pelvic floor dysfunction is common, it's very common, it's not normal. But we as a society have normalized it. In preparing for this presentation, one of the research articles that I read called it the hidden epidemic. And why did they call it that? Why did they call it that? Because two-thirds of first-time moms will suffer from some type of pelvic floor dysfunction. 66%, guys. And no one's talking about it. And with every birth, we have an increased risk, right? So these are huge numbers of women who are living with it. We're living with it. And it's normalized. We see, on a sitcom on the TV, we will see talking about mom bladder. Oh, gotta cross your legs to sneeze. This is portrayed as normal. When I was reading a novel last week, there was a part in the novel where a mom and her 13-year-old daughter are going to the basketball game, and the mom's not supposed to get out of the car. And they pull up to the basketball game, and the mom says, oh, I'm going to get out. And the daughter says, you said you weren't getting out. And she said, but I have to use the bathroom. The daughter says to her, but you used the bathroom before we left. You always have to use the bathroom. The mom says to her, you can thank the fact that I was in labor with you for 32 hours for the fact that I can't hold my bladder. The daughter's 13 years old. Okay. But this is what Sarah was talking about in research, right? Yeah. She's talking about 1 year postpartum, 2 years postpartum, 43%, 13 years postpartum. We're not measuring that, but women are living with it and they're still suffering 13 years later. And we're normalizing it, right? This is something we're casually talking about in a thriller novel, right? Really important. This is why it is called the hidden epidemic. And we had talked a little bit, I said there's not a whole lot of perinatal specific research, but there are a few really good studies that brought some really good information. And I want to talk a little bit about those. In 2017, there was a study that looked specifically at pelvic floor trauma and vaginal birth. And this study really confirmed the long-term sexual dysfunction and relationship issues that women are reporting related to pelvic floor trauma at birth. And this study again confirmed women are putting up with these injuries. The women in these studies, that's one of the things I said, we're living with this. They're all reporting a reduced quality of life. So that study we talked about earlier, here we're seeing it again. These perinatal women are again saying the same thing. They're having increased anxiety symptoms, particularly around sexual function, and experiencing feelings of self-blame. I did something wrong because my body isn't working right. And now the things that I could once do, I can't anymore. And it's creating an issue. And with pelvic floor trauma, there's a risk for postpartum or for post-traumatic stress disorder and for increased trauma symptoms in the postpartum period. really important stuff, right? We're looking at lots of risk for trauma, not just mood disorders, but long lasting trauma and relationship disorders also. In 2022, there's another really important study, and this study really looks at the importance of education. And that's one thing that will come up as a theme through here is lack of education. And it looks at the importance of education in mitigating the mental health symptoms related to pelvic floor distress. And what this really said was that individuals who reported higher discrepancies between their expectations and their experience had the highest strong associations between pelvic floor dysfunction and mental health symptoms. So those who are blindsided or caught off guard, right? And again, we shouldn't be because this is so common, but so many people are. And this study confirmed what we know, which is that knowledge regarding pelvic floor dysfunction remains incredibly low among pregnant women. And women who do know are getting this information from social media, from TikTok, and from their friends. They're not getting it from their providers most often. They're not getting it from the people who they're coming to help them make informed decisions about their birth. And again, that the pelvic floor dysfunction in this time period really impacts that physical health, mental health, and activities of daily living for these women and for their ability to care for their families, right? In 2023, there was a study done that looked at the impact of receiving both therapy and treatment for pelvic floor dysfunction. And why is this important? Because it tells us how important it is for women to be getting holistic care. But also, this study was really important because this study identified some of the barriers that women were reporting. Perinatal women were reporting lack of knowledge about pelvic floor dysfunction. We're hearing that as a theme now. People don't know about it. There's also a reluctance to go to the doctor for treatment related to feelings of shame and embarrassment. So most women are not going to the doctor until it's a crisis, right? They are living with it unless it's a crisis because one, they think it's normal. Two, they don't know that there's treatment for it. And three, it's embarrassing. And then for those who do make it to the doctor, this time period presents a really special challenge. And what is that? Lack of time to take care of yourself, right? Most everyone in this room has had a child. And so these are women who maybe aren't finding time for a shower, who maybe haven't eaten today, but we're going to maybe ask them to do some pelvic floor retraining. And so the compliance is not great in the early postpartum period, right? Which is sad because it increases those risks of mental health issues. And there can be more related to not being able to do your exercises, right? And feelings of self-blame around not having time. The final study that I included in this piece, I included because it was the only really excellent study that I could find. It's a very new study that looked at data analysis across the world. This was a study that compiled 47 different articles from countries including the United States, Canada, Australia, Asia, Africa, Europe, the Middle East, and South America. And what the study showed us was that all across the world, in all these different countries, the same things were showing up. All of these studies were showing depression, anxiety, and trauma-related symptoms specific to pelvic floor dysfunction. And this study also got to break it down a little. So these findings suggested that incontinence is associated with higher levels of anxiety and depression. Sexual dysfunction is related to greater risk of postpartum depression. And pelvic floor trauma is associated with those PTSD symptoms. What this study also told us is that women who do have a pelvic floor trauma are at the highest risk of experiencing severe postpartum mental health complications. So this study suggests that when we know that a woman has had a pelvic floor trauma, that they are screened more frequently for mood and anxiety disorders because across the board, these are the women who are having the most extreme types of symptoms. What do we know about rural and marginalized populations in this topic? There was a study in 2022 that looked actually at rural populations. There's very little research, but there was a rural specific study. And postpartum women residing in rural areas may experience really unique barriers to accessing care. And that can be pelvic floor care, that can be OBGYN care, that can be doula care, like any kind of healthcare. And that's related to geographical isolation, lack of transportation, lower socioeconomic status, and lack of health insurance. And in the area where Sarah and I are from, we know that provider ability is so impacted. So you might want to see a pelvic floor physical therapist. You might want to see a perinatal therapist. You might also be on a waiting list for 6 months. So this is a rural specific barrier that we see. And we also know that rural cultures emphasize self-reliance more than urban cultures do. And these women may face additional stigma around seeking care for pelvic floor dysfunction, mental health, or gynecological care. In 2022, Johnson et al., and we talked about them a little before, they did look a little bit at Black, Hispanic, and non-white populations, but mostly what they were able to tell us is that they're underrepresented in pelvic floor research, and that these populations had lower levels of knowledge surrounding risk factors, symptoms of pelvic floor dysfunction, and less knowledge of what treatment options were available. Research tells us we can do better, and we've talked a lot about that. In 2023, there was a study that told us one of the best ways that we can do better is by providing people with therapy and treatment for their pelvic floor dysfunction hand in hand. So women, first-time moms who received both psychotherapy and pelvic floor physical therapy had the best outcomes in regards to their mental health of women who just received one or the other. In 2022, there was also a study that again told us that women delayed treatment until disorders were severe. And that was partially due to lack of knowledge around pelvic floor health. Again, they're not knowing that there's something you can do about this. We just think you're a mom, you had a baby. Sorry, bummer for you. And so they're not saying, no one's saying, go to the doctor. It doesn't have to be this way, right? So they're not getting treatment because they don't know. And this study was really interesting because it found that exposing women who are pregnant to a one-time video-based education done by a certified pelvic floor physical therapist actually increased their odds of having better mental health outcomes. Just being exposed to a one-time video, even online, that gave you information, gave you a better outcome, right? This is a simple thing that could be implemented. Research tells us it doesn't have to be hard. It just has to be talked about. And finally, again, the individuals who felt blindsided by their injuries had such amplified symptoms. The anxiety, the depression, the trauma was so much more severe. And it is really important to provide pregnant women with the accurate information about pelvic floor risks, just as we provide them with information about mood and anxiety disorders if we're doing our job at its best level. We've spewed a lot of information at you, and we've inundated you with what a pelvic floor is and about mental health. But what does this sound like in my office? I am not a pelvic floor physical therapist. So people are not coming to me and saying, I have incontinence or I have a prolapse, unless they had a trauma. Then women are coming to you and they're saying, I had this birth trauma. Let me tell you about it. Here's what's going on. Best case scenario. What most people are coming to your office and saying is, here's a picture of a mom peeing her pants, jumping on a trampoline. My kids want me to jump on the trampoline and I pee my pants when that happens. And it bums me out. Like, I want to be able to do it, but I can't. Or I used to love going on walks with my friends, and my friends invited me on a walk the other day and I had to turn it down because I didn't know if I'd be able to get to a bathroom in time if I had to go to the bathroom. Or I had my baby 7 months ago and my husband and I still can't have sex and it's really causing a problem. He's really upset. We're having a hard time connecting, but I can't even think about it. The pain is so bad. I can't even think about entertaining the idea. And it's causing this big problem, right? This is what we're hearing in our office. And so what is my job then? What's my role as a mental health professional, right? It's really important that I stay in my own lane, right? So ultimately my job is to treat the mental health symptoms, to explore when people are talking about this, what's that looking like for you? Is that increasing your anxiety? What's that doing for depression? To explore those symptoms, but it's also to provide education. And it's to let women know that it might be common, but it's not normal. We might be educating them for the first time that these kinds of impacts do have impacts on lots of women's mental health, that it's normal that you're feeling anxious because this is happening. It's normal that you're maybe feeling some depressed symptoms, really common, right? And it might mean that we're helping our clients build confidence to speak with their provider to advocate for a referral for treatment, because so often doctors are actually dismissing women who are coming in with these concerns. Like Sarah said earlier, don't worry, you just had a baby. So sometimes women have to be able to self advocate, and we as therapists can help them to have that skill and that courage to practice advocating to get the treatment that they need. And because, especially in rural populations and with minority populations, referral times can be so impacted. We talked about that earlier. You might be waiting 6 months. We as therapists can provide resources for our clients that can help them get more information in the time while they're waiting. And of course, again, for those of us who are therapists, it's really important for us to remember that we can best help serve our clients if we get them in to the other treatment they need at the same time.
The information shared in this podcast by Sarah, Allison, and our guest interviews are intended for educational, entertainment, and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. While we are licensed physical therapists, we are not your personal physical therapists, and no patient-provider relationship is formed. If you have any health